Well, great. Good morning. Welcome, commissioners and members of the public, to the first fully virtual public meetings of the Massachusetts Health Policy Commission. From everyone here at the HPC, we hope that you and your loved ones are well and healthy during this time. For the members of the public and market stakeholders who are watching this meeting on our live YouTube channel, thank you for your ongoing engagement and interest in the work of the HPC. You may find today's slide presentation and accompanying materials that we will review this morning available on our website. Now, there's a link on our homepage to the committee meetings page, or in an email newsletter, or on our Twitter. We do encourage you to follow us on Twitter at @mass_HPC for the latest news on the Health Policy Commission. We really hope to stay connected to you in this new virtual world. Today, the two policy committees of the Health Policy Commission will be meeting back to back, beginning first with the Market Oversight and Transparency Committee for the first hour, and then transitioning to the Care Delivery and Transformation Committee at 11 a.m. Both meetings will be continuously streamed through this YouTube channel. Before we turn to today's agenda, I'd like to first turn the webcam over to the Health Policy Commission's esteemed board chair, Dr. Stuart Altman, for some opening remarks.
Well,
Stuart, it's great to see you.
Thank you so much, and it really is a pleasure to be back. Took a little longer than I expected, but I'm back and really excited about this meeting. I've gone through the slides, and I'm really looking forward to a very active discussion among the commissioners with respect to this new world we're living in, and to what extent it will influence our ongoing activities. Hopefully, whether it's in June or at a later date, we'll get together in person. I'll get a chance to, if not shake hands, at least rub elbows or whatever. But it's good to be back, David. And I'm going to turn it back to you. Given the complexity of the technology, it's better that you run things the best, and make sure that everyone that wants to speak does so. So David, thank you. And I want to again thank all the commissioners for the cards and letters and good wishes during my long illness. So thank you. David?
Great. Thank you, Stuart. It's great to have you back. And as Chair Altman mentioned, we are joined here this morning by a number of other Health Policy Commission board members. So I want to acknowledge them. We have Commissioners Marty Cohen, David Cutler, Barbara Blakeney, Dr. Kreider, Tim Foley, Ron Mastrogiovanni, Dr. Don Berwick, and Cassandra Roeder on behalf of Secretary Heffernan, all joined us in Zoom today. These are members of both of the policy committees meetings, but wanted to participate as much as possible in the agenda today. So I really want to thank all of the board members for taking the time this morning, especially during this busy time, to participate in these meetings today. Also in our Zoom room on our end is a few members of the Health Policy Commission staff who will be presenting today, and I will introduce along the way. I also want to acknowledge all the Health Policy Commission staff who are watching today on the YouTube channel. Thanks for being with us. As Stuart said, we have a full agenda today with new information on a number of important topics to the Health Policy Commission. But before we dive in, Colleen Elstemeyer, the Health Policy Commission's Deputy Executive Director, and I wanted to provide just a brief update to the board on the HPC's work and operations since our last public meeting on March 11th. First, since transitioning to a fully virtual workplace on March 13th, the work of the HPC has continued without interruption. In addition to our ongoing responsibilities, I'm proud to report that the HPC staff have been working hard to provide any and all support as requested by the state's COVID-19 Response Command Center, led by Secretary Mary Lou Sutters. This is truly an all hands on deck situation across state government, and the Health Policy Commission, along with our sister healthcare agencies, have all stepped up and volunteered to do and provide whatever research, data, and staff that we can to help. We're committed to doing our small part to leverage our data assets and expertise to help support the critically important work of the COVID response effort, particularly with regard to hospital surge planning and preparedness. The Secretary has assembled a fantastic team at the Command Center, including Undersecretary Lauren Peters, and I want to personally acknowledge their incredible leadership and tireless work on behalf of the Commonwealth over the past 2 months. We're proud to help in any way that we can. Finally, and most importantly, I want to acknowledge the tremendous work of our healthcare stakeholders and our frontline workers and essential workers for their heroic efforts to manage this crisis and for their efforts to provide excellent patient care every day under extremely challenging circumstances. We support you and we thank you. So for more insight into the HPC's operations and for a few friendly public service announcements, I'm going to turn it over to Colleen Elstemeyer, Deputy Executive Director.
Great. Thank you so much, Director Seltz. As David said, I'm going to provide a brief update to the board on HPC work and operations, as well as a couple of public service announcements. First, as David said, the HPC is fully remote and open for regular business. We continue to receive public inquiries via email and phone. If you would like to contact the HPC for any reason, our contact information is here on this slide. As David said, our ongoing work streams, research projects, publications continue apace as before, as you'll see today. Our staff was able to very successfully and smoothly transition to a remote workplace 7 weeks ago. And with a small agency like ours, we've been able to maintain collaboration amongst the team and stay in close communication with each other. Productive and frequent internal and external communication is extremely important for both how we conduct our work and our health and wellness. So like everyone else in the world right now, we have a lot of Zoom meetings. Regarding reopening the Boston office, we're following the guidance and requirements from the Baker-Polito administration, as well as our public health officials. We plan to assess reopening our office on a regular basis and continue to make the top priority the health and well-being of our employees. I wanted to particularly thank you, our commissioners, for your accommodation and patience as we transition to this new world of remote engagement. Public meetings, as you all know, are a big part of how the HPC does its work, and we appreciate all of your positive attitudes and receptiveness to doing things a little differently. So thank you. So a very important part of our work, as you all know, is the HPC's Office of Patient Protection. OPP is operating remotely, assisting patients and protecting the rights of healthcare consumers. Since beginning remote work 7 weeks ago, OPP has been actively assisting consumers by processing external reviews, redirecting consumers who need access to health insurance, and answering calls on the hotline. So before I move on, I just want to particularly shout out our friends and our sister agency, the Health Connector. This is our state-based marketplace, working to ensure that Massachusetts residents losing their jobs and job-based health coverage can swiftly and easily maintain their way into health coverage through the connector. The Health Connector is actually designed to help people in exactly these circumstances, but that help can only work if people know to go to their website, which is mahealthconnector.org, to apply for coverage. So in Massachusetts, we're especially fortunate to have the unique Connector Care program, which connects qualifying Massachusetts residents with affordable health coverage with low or $0 premiums on low copays and no deductibles. So we want to make sure that everyone in Massachusetts knows that if they need coverage, they can do so through the connector's special enrollment period this year, which runs through May 25th. And at OPP, we've seen a significant benefit from the connector's open enrollment extension. We've been able to redirect consumers back to their insurance carrier, back to their broker, or back to the connectors to be able to maintain coverage. So thanks to the connector, we can keep Massachusetts residents covered, even in the midst of significant economic challenges and change. So again, for the public, the website is mahealthconnector.org. And then on the next slide, for the public audience, wanted to provide the contact info for OPP, so everyone has that. So to close out, I just want to highlight two very, very important COVID-19 related initiatives that we're really trying to promote during this time. Would ask that you promote with your networks as well. First, the month of May is Mental Health Awareness Month. So we wanted to share and promote the resources available at NAMI. NAMI, as our commissioners know very well, is the nation's largest grassroots mental health organization. NAMI is here in our community to help if you or a loved one is struggling. We all know these are tough and uncertain times, and our mental health matters, and we are not alone. So visit NAMI.org to learn more about the free programs and services that are available. More contact information is highlighted on this slide. There's helpline and text information. So please feel free to share and promote this slide. This is also being tweeted out right now on our social media platform. Our handle is mass_HPC. If you want to retweet to help get the word out, we'd really, really appreciate that. So finally, another important initiative that we want to promote and would ask that you promote is around the essential work of community contact tracing. So the state, along with Partners in Health, has created the COVID-19 Community Tracing Collaborative. This is a first in the nation initiative focused on tracing the contacts of confirmed COVID positive patients and supporting individuals in quarantine. So as you have all heard announced from the state's COVID-19 Response Command Center, the collaborative is deploying nearly 1,000 contact tracers throughout the state to connect with COVID-19 patients and their contacts to support our efforts to track and contain the virus. So the contact tracers first connect COVID positive patients with support and resources they may need throughout quarantine. And then in collaboration with the patient, they reach out via phone and text to anyone the patient has been in contact with to trace and contain the onward spread of the virus. This effort is critical for our state's ability to help those who've been potentially exposed to the virus. So when the MA COVID team calls, we need to get the word out that people need to answer their phones in order to connect with these tracers. So we need people to know, and this is really important, phone calls will use the area code 833 and 857. And the phone will say the call is coming from the MA COVID team. And also we need people to know that the calls are only going to be made between 8 a.m. and 8 p.m. So please, please help get the word out, help control the outbreak, help prevent future waves of the infection. More information about the COVID-19 Community Tracing Collaborative can be found on the state's website, mass.gov. So both of these and the information about the connector special enrollment period, just signal boosting and asks for you, our HBC community, and our board members to help get the word out as well. So that's it for me. With that, turning the agenda back over to Executive Director Seltz. Thank you so much.
Great. Thank you, Colleen. And Colleen has been our internal HPC COVID chief and has done just a truly excellent job in leading the agency into this new world. So thank you, Colleen. So Chair Altman, I think we're ready to move into the first committee meeting, the Market Oversight and Transparency. So I'm going to actually turn it over to the chair of this committee, David Cutler, to briefly introduce the agenda and lead us through a vote on the minutes for this committee, which we will need to take by roll call in this virtual setting.
Thank you, David Seltz. Good morning to everyone. It's great to at least see everyone here, and I hope everyone is safe. As David said, we have a few issues which we'll cover in the next hour or so from the MOAT committee. The three biggest issues are, one is information on the CHIA reporting timetable, some of which has been set back in time, but some of which will actually be helpful to our work. So we'll go through some of that. Second is obviously talking about COVID-19, and one of the issues that's particularly within our purview is the impact on medical spending. And so we will talk some about that. And then third is on out-of-network billing. And so we'll have a little bit of discussion there. The first thing we do need to do is to approve the minutes of our previous meeting, which was on January 14th. And so the commissioners who were there were myself, Rick Lord, Ron Mastro Giovanni, and Cassandra Roeder. So the four of us are the ones, because we were there, the four of us are the ones who should vote to either approve or not approve the minutes. They were distributed. I guess I'll ask my colleagues if they have any comments or thoughts about it, or a motion to approve the minutes. You should take yourself off mute. Ron, do you want to offer a motion to approve the minutes? I saw your, actually, you're still on mute, Ron.
This is Cassandra, so moved.
Okay.
So moved. Yeah.
Okay, so we have a second. So I now, I think we need to go by roll call. So I vote to approve the minutes. Rick, I don't see your picture, but you're here. Are you here, Rick Lord?
I don't believe Rick is here, so I think it's just you, Commissioner Mastro Giovanni, and Cassandra.
Okay, Ron, do you vote to approve?
Approve.
Okay, and Commissioner Roeder, do you vote to approve?
Approve.
Okay, so then the minutes are approved. So I'm going to now turn it back over to David Seltz to talk about the timeline issues related to CHIA's reporting timeline for medical spending and how that affects the HPC calendar. Obviously we'll have time for discussion. I think if people want to, so I've discovered from teaching, you can raise your hand, or you can just, so you have a virtual hand, or you can just be in the group chat. If you want to say something, just say, hey, look, I'd like to make a comment or ask a question. And so David, back to you.
Great. Thank you, Commissioner. So the first agenda item today, as Commissioner Cutler teed up, is an important update on the data reporting deadlines at the Center for Health Information and Analysis and the implications this represents for our calendar of work on an annual basis. This does have implications for the timeline by which we measure health system performance, including our performance against the benchmark, and also our timeline for holding certain entities accountable for excessive spending that threatens the benchmark through our HPC's performance improvement plan process. So I'll walk through some of these key changes and what they mean for the HPC. I would note at the top that we have been in discussions with our colleagues at CHIA about a potential change in the timeline for over a year prior to the COVID outbreak in order to explore alternative schedules that would accelerate certain data reporting necessary for the ongoing implementation of Chapter 224. So as I'll walk through, there are practical realities that necessitate making this change this calendar year, but there are also certain longer term benefits that we believe may outweigh the disruption in this one-time transition to a new calendar cycle. So as you know, CHIA collects a range of key data about the healthcare system and spending throughout the year. Recognizing that health plans and providers are focused on responding to COVID-19, CHIA, in consultation with the HPC, has elected to change some of the timelines and requirements for reporting data this year as shown on this slide. Specifically, the TME data, alternative payment method, premium, prescription drug rebate, and relative price data that is all normally reported by payers to CHIA in spring and early summer will now be due to CHIA in September and October. Additionally, the new behavioral health and primary care expenditure assessment that CHIA was launching for the first time this year and that we have been supporting will be due in December. Most notably, absent this reporting change, the TME data that is important for our performance improvement plan process that would have been reported in May would have included the final data for calendar year 2018 and the preliminary data for 2019. And as a reminder for commissioners and the public, the confidential list of entities that is forwarded to the HPC from CHIA is always based on final data. So there has been an extensive time delay on this list due to the fact that every year we only get preliminary data for the immediately prior calendar year. However, as noted in this first bullet here on this slide, under the new revised timeline, the TME data that will be reported to CHIA in September will now include final spending for both calendar year 2018 and 2019, or the previous calendar year, rather than that preliminary data that necessitated an almost full year delay. This means that under the new reporting timeline, we will actually be able to accelerate accountability under the healthcare cost growth benchmark by almost 8 months, since the final TME data will now be collected in September rather than the following May. Accelerating this timeline has been a priority for both the HPC and for CHIA for some time, and I know has been a topic of conversations by commissioners in many of our meetings. The new reporting timeline also has other implications for the HPC calendar, as noted on the bottom half of this slide. Specifically, since CHIA will now be collecting the TME data in September rather than in May, it is likely that they will be issuing their annual report on healthcare spending next January rather than the typical September. And this suggests that the HPC would then follow with our cost trends hearings, not in the typical fall timeline, but now in a spring timeline. So this part of the process will be delayed by a few months compared to the normal process. But on balance, we think there are benefits to be had from accelerating the ability to get final data as opposed to the two-step preliminary and then final data. On this next slide, you can see how all of these timelines sit next to each other. So again, you can see the differences between the TME data collection moving till September and the fact that that will include final data for 2 calendar years. The CHIA annual report moves back a few months. Our cost trends hearings moves into the spring. And the referral process, as mentioned before, will be accelerated. So this is a significant change in our annual cycle. I would note that this year, we still are holding the dates in October that were previously scheduled for our cost trends hearings. And I think open to discussion by this board at future dates, whether it still makes sense to hold an event perhaps in the October timetable, maybe not a full cost trends hearings, but another type of event to take a pulse of the healthcare system and to engage experts and stakeholders in a post-COVID conversation. So finally, as we're talking about accountability under the benchmark, we thought it would be worth just a few brief thoughts on the process of setting the benchmark during this time as well. I would note that this topic will be a longer board discussion at our next regularly scheduled board meeting in June. Because as you know, the HPC is required by law to set an annual benchmark for healthcare cost growth. And we expect to set the benchmark for 2021 at that next meeting in June. We obviously know that the COVID pandemic is posing a tremendous challenge to the healthcare system and is likely to have significant implications for spending trends in 2020 and beyond, as we'll be discussing in further detail in our next agenda item. And particularly in the time of COVID-19, robustly analyzing spending growth will be critically important to allow us to understand both the short-term spending impacts and long-term implications of the pandemic on the healthcare system, and to whom who is bearing some of those costs. I also want to clarify that the benchmark and the performance improvement plan process are specifically designed to understand healthcare spending and the factors that drive increased spending over time. The benchmark is always a long-term strategy, not an annual spending cap. And the benchmark and performance improvement plan processes are also specifically designed not to penalize health plans or providers for spending that is outside of their control. By statute, the HPC has to consider factors outside of an entity's control as part of our review process. And certainly the COVID-19 pandemic and resulting disruption will be weighed heavily as the HPC analyzes spending performance this year and beyond. We expect to have a longer conversation on this topic and on the benchmark at the next board meeting where we will take a vote to set the benchmark, but did want to raise some of these thoughts here today. So I'm going to pause now to open up for comments or questions both on the revised timeline and the implications that means for our annual cycle, as well as any other additional comments.
David Seltz, can you go back to the revised timeline chart for 1 second? Yeah, that one there, thank you. So some of these changes are obviously valuable in our work in terms of being able to do things sooner, and other things are a little later, that is the total medical expense. Do you expect that, or does CHIA expect that after this year, the total medical expense for the previous year's calculation would return to its regular timing? Or do they think this is likely to be a permanent change in that?
I think that is still an open question, Commissioner. I would say that one of the benefits of a September reporting timeline is that we believe that is sufficient time to be able to have final data from the previous calendar year. As part of our process for investigating a potential change that, as I mentioned, was happening even before this current crisis, both CHIA and the Health Policy Commission talked to many health plans about when they think an appropriate timetable may be for them to have final data that they could report to the state. And many health plans indicated that a 6 to 12-month runout was necessary in order to adjudicate all of the claims and potentially non-claim spending. And so this is basically a 9-month runout from the previous calendar year. And we believe from our survey of health plans will get us to near final, over 95% data collection and accuracy. So really trying to strike a balance between accelerating the timeline, but also ensuring that we have the full runout so that we can call this final data as opposed to preliminary data. So I think there is an advantage to the September timeline that we may find persists beyond this calendar year.
David, can you hear me?
Yep.
Okay. Well, I've thought a fair amount about this, and at one level, the particular amount that the benchmark would indicate may be a bit fictitious for this 1 year with all of the differences that occur, but the concept of the benchmark is really very important. It really undergirds much of what we do. And as you and I and others have gone around the country, most states have been very interested in the concept of the benchmark. So as we think about at the next meeting what the amount is for this coming year for the benchmark, I think we need to be less concerned about that and use it as a kind of a guide. But the concept of the benchmark needs to be maintained. We will have future years to decide what that appropriate amount is, but I don't want to, and I really like this new time. You know, and a few others have been very concerned about the long lags, particularly for our PIP process. So I'm really very pleased, in a way, the necessity of moving it because of everything else happening. With respect to David Cutler's question, I hope this becomes permanent in terms of moving it out so we get a final number we can also be closer to the time when we do the PIP. So this is, I think, a very good move.
Great. Thank you, Chair Altman. And as we know, even in our history here in Massachusetts, there have been years where spending has exceeded the benchmark. And part of our process is understanding why and what is driving that, and is there value that is being generated from that. And so it is an organizing principle for being able to consider and understand all of these dynamics more than anything. Commissioner Berwick, I noted that you raised your hand and would love to.
Yes, David. Just quickly, I like the new timeline a lot for the reasons you articulated. It's also respectful of the stresses that are on the healthcare delivery systems right now. I'll give them a little more breathing room in terms of reporting, I suspect. The issue of the benchmark, which I look forward to talking about at our meeting, this is also being dealt with at the federal level by CMS with respect to how to benchmark the ACOs for their savings. And we might take a look at how they're attributing COVID costs versus non-COVID costs. That's going to be a technical issue. And we'll have to look very carefully to make sure that we don't bake in evanescent COVID costs into the benchmark in the future. So it's going to be an interesting conversation in June.
Great. Thank you, Commissioner. And Commissioner Cohen?
Yeah, I also support the timeline changes, but I'm just wondering, David, if you could comment on what you think the current PIP reviews will mean given where things are today.
So we are currently in a review process for a PIPS list that we received late in the fall. For the moment, we have continued the internal work on reviewing the spending performance of those entities that have been referred to us. But out of respect and acknowledgement for the importance of other work that these entities are doing right now in responding to the COVID crisis, we have taken a pause on kind of the reaching out to them and asking for documents and data, as is part of our normal process. Just for this particularly challenging moment, it's important that we not add additional administrative burden and reporting burden right now. So while our internal work continues, we have pressed pause on kind of the external outreach. I think there will be continued conversations of this board around how to close out the current review process and what information we need to gather to answer those questions. But and would be happy to give, I think, a further update on that maybe at the June meeting. But for the moment, internal work continues and want to give a moment before reaching back out and asking for documents and data from the entities.
Great, makes sense.
Seeing no other hands raised, I think we can move on to the next agenda topic, which is really an introduction to a conversation. And I think really want to be able to have some commissioner conversation on this point today. So first, I just want to preview this by saying that, the COVID-19 pandemic represents a truly unprecedented disruption to our state's healthcare system that will result in unique challenges now and in the future. So today we wanted to begin a conversation and discussion with you about how best the HPC could leverage its data assets, research expertise, investment experience, and market knowledge to support policy efforts during and after the crisis. And in particular, as Commissioner Cutler said, core to our mission is understanding healthcare spending trends and costs and the overall market structure of healthcare in Massachusetts. I would note that any such efforts would need to be highly coordinated with the administration, the legislature, and other state agencies, and obviously appropriate to our statutory mission. So we're not here today necessarily to present answers to you, commissioners, so much as to present some of the important questions that healthcare stakeholders, policymakers, and experts have all identified as critical for informing the next phase of healthcare policy in Massachusetts. So today we're going to present some initial thoughts on key dynamics and effects on spending and utilization, potential impacts on market participants, and some implications and opportunities for future work. To inform this discussion, the HPC examined many sources, including industry reports on utilization trends, estimates of COVID-related spending, and expert opinion pieces and news articles. The extensive sources section at the bottom of this slide summarizes the very numerous articles and research papers we reviewed in preparing the information on the next few slides. And I would note, including some articles authored by some of our own commissioners. So thank you, commissioners. And with that, I'm going to turn it over to David Auerbach, our Director of Research and Cost Trends, to present on the next few slides.
Okay. Thank you, David, for that introduction. Okay. So as you noted, this first slide is running down a summary of what we know from several industry reports and other sources on the immediate impacts of the COVID-19 pandemic on healthcare utilization and spending by the different sectors in the healthcare market. And I'll just note, this is national data, but some of these sources have broken out some of their reports by region of the country. So where that was done, I'm using data from the Northeast. And these are industry aggregators who are collecting data from a number of providers. It's not necessarily representative in the same kind of research we normally present, but this is the best source of information we have right now. And this concords with what people are seeing and hearing on the street for the most part. So starting with hospitals, one report is noting changes in utilization over the course of March 2020 versus March 2019. Now, of course, March 2020 was not fully affected by the stay-at-home orders. So if you were thinking about April, for example, you probably want to even double some of these numbers. But as we've heard, significant drops even in March 2020 compared to 19 across the board in the hospital. Drops in discharges, patient days, operating room minutes, and even ED visits, which you might think would be less affected by 14%. And in terms of overall hospital revenue, we're seeing drops of 15, 20%, so higher in the outpatient, where care tends to be more elective or more scheduled. Very large effects. Occupancy rates on average falling from about 65% to 53%. Okay, so we see even larger drops in physician office visits, where care tends to be, again, more scheduled and more elective. Overall, through April 12th, reports are finding about a 2/3 drop in office visits. And you can see on the right that varies by specialty or by type of visit. You see smaller drops in areas of behavioral health, for example, which are more able to be done remotely via telehealth, about 50% for adult primary care, and even more, about 2/3 in some specialties like surgery and dermatology. Again, to note, telehealth has had a very large rise across the board. So this drop in physician office visits would have been around 80%, but telehealth has been able to backfill about 1 in 5 of those lost visits. So bringing that reduction to about 2/3 overall. We see drops in prescription drugs, especially in new prescriptions that would tend to be initiated by an office visit, down around 27%, and drugs that need to be administered in an office, not surprisingly, down again by about 2/3. And then labs and diagnostic tests, again, often initiated through an in-person office visit, down about the same, about that same 2/3. This is all data through around early April. Okay, next slide. So those are some of the immediate effects, mainly brought on by the shutdown and the stay-at-home orders. So this slide then translates that as well as we can into what this means for provider revenues. And we're showing broadly effects on hospitals with the hospital icon, and then on physicians or professionals. And you can see several categories of effects here that are not surprising. As we showed just now on the left, starting with major reductions in revenue are coming from all of that displaced and lost care that we were just going over. And that affects both hospital and physicians for sure. Then there are some areas where revenue would be increasing, particularly for COVID-related care, for sure, more in the hospital than in the physician sector. And there is significant federal and state support for providers in that third bucket over there. So those are increases as well, and those are substantial. And then in the last bin, it's important to note that there are substantial shifts away from commercial coverage. A recent report by the Robert Wood Johnson Foundation and the Urban Institute was expecting that, for example, if unemployment rates rise to 15% in Massachusetts, and they did a state-by-state analysis, they're projecting something like a 10% loss in employer-sponsored coverage, with some of those flowing into Medicaid or the connector and some remaining uninsured. And loss of commercial coverage from the provider perspective for sure means lower payment rates, because commercial payers tend to pay much more than public payers. So again, all of those effects, we're not showing numbers here. We know something about expected magnitude, but there's a lot of uncertainty. And these will vary by provider based on the kinds of revenue streams they have, their financial health before the pandemic, their payer mix, and other factors. And then looking at the perspective of the insurers, the commercial payers, most people tend to think that overall over the course of 2020, that claims costs would be down on net. So more from these reductions in that left box than all of the increasing areas. But that drop would be in claims cost, which should benefit insurers, but those drops would be offset by, for example, loss of commercial coverage, increased costs related to COVID, such as testing and treatment, reduced investment earnings, and additional payouts through shared savings on their risk contracts, or in some cases, hitting the minimum loss ratio thresholds.
David, David?
Yep.
I want to go back to the hospital area. I think we need to do as best we can in the next meeting and meetings after that to break the hospitals down. My sense from what I've been reading, and I'm sure other commissioners, is that the impact on hospitals varies substantially depending on the kind of hospital it is. Our rural hospitals and many of our community hospitals have really taken the brunt of the reductions in admissions. Most of the sickest patients, of course, have wound up in our major academic medical centers. Whether this will turn around after COVID has been reduced or not is going to be critical, because we as a commission have been very strong in our emphasis of trying to maintain a viable and active community hospital system. And the question is going to be whether the COVID experience sort of really tests that. So I would ask you and the staff to go back and really look in depth as much as you can about what we can find out about the differential impact that COVID is having and whether it will have lasting effects. The second thing, which again is a placeholder, is there's been a fair amount of criticism and much about our delivery system not being up to the early challenges. And the key here is going to be, we have a very decentralized delivery system. We sort of moved away from any form of health planning of the 1970s and 80s. And while there are big advantages to the decentralized system, there are some glaring problems. So as we think about the future and the role of the HPC, we need to look in how we buttress our decentralized system so that if something like this were ever to happen again, we'd be in a different position. So I just want to put both of those as placeholders for future discussions.
Okay.
Thank you, Stuart, and absolutely agree. I think we understand that the impact is going to vary dramatically depending on what sector, the individual organization. And while on this slide, we're showing some of the kind of so-called big buckets, I think understanding the net impact of all of these different dynamics is going to be very critical to inform future policy action, future legislative action, future financial support for the industry, so that we're carefully accounting for all of the both net reductions and in places where both the state and the federal government have stepped up to make enhanced payments and accelerated payments. And so understanding all those puts and takes from a Commonwealth situation, I think will be very critical. And we, of course, would stand ready to help support that effort. All right, David, I'm going to let you do the last slide, and then we'll move to discussion.
Great. Okay. Thanks. So the next slide just goes over more qualitatively some of the expected impacts on the healthcare system from the COVID pandemic. And this is divided into immediate impacts and some of the medium and longer term impacts of what's going on right now. The immediate impacts, we've mostly gone over these major reductions in non-COVID care, as well as increases in telehealth and in COVID-related care. It's also important to note that some of the care sectors that particularly care for the elderly, such as post-acute care and long-term care, have had major disruptions in how they do business and how they care for folks, and major disruptions to the provider workforce as well throughout everything. And those are important aspects to keep abreast of. And then in terms of some of the medium and longer term impacts, so here we are seeing care reductions in the amount of care being delivered, up to 2/3. And then what happens as we start to open up? And there's a number of different ways that are happening all at the same time. Some care that has been put off or reduced probably will not come back. And in some cases, that's not always a bad thing. You can think of some kinds of low value care or care that could be managed equally well at home or through medication versus an intervention or a surgical operation. Some substitution of in-person care for telehealth visits will probably remain as people get used to that mode of care, which can be equally effective. Other categories of care that are displaced, for example, knee replacements, will probably return. Although I'll note there will certainly be some queuing and some waiting as people try to get back in a system that's only partly back operational again. And there are other kinds of care that's being put off that could potentially come back in a more acute, exacerbated form, such as people not getting maintenance care for chronic conditions right now. There are, of course, costs related to treatment and vaccines, which we really don't know exactly how that's going to play out, but it could be certainly significant. We're probably already seeing increased demand for mental health and substance abuse services due to the disruption and the economic and other effects of the stay-at-home period. And we are seeing signs that whatever disruptions we have or access problems related to social determinants of health could very likely grow and increase. Okay. So let's move to some of the implications of this for the HPC.
So thank you, David. And so for the final slide on this agenda item, just wanted to, again, begin a conversation on some of the potential implications for our work. And I'll just say a few words on this slide and then turn it over to Stuart to lead commissioner discussion. And I want to reiterate again that some of these potential areas for exploration may appropriately be led in coordination with other state agencies, and the HPC could play a supportive role by leveraging our data and independent expertise. But many of these are consistent with our statutory mission and work streams, but through a COVID lens. And so potential work could include modeling differential impacts on different types of provider organizations as Chair Altman said before, understanding the impact on community hospitals as compared to large academic medical centers, rural hospitals compared to urban safety net hospitals may all have different experiences and impacts. Physician practices that do not have hospitals, we know have also been impacted through this crisis as many of their utilization and revenue has decreased. And community health centers have played a critical role as well in serving their communities and providing care. We expect that there may be implications on market structure, and of course that is a continued priority for the Health Policy Commission to examine those market changes that may result in a post-COVID world. We continue to prioritize primary and behavioral health care. This was one of our really top policy priorities in last year's cost trends hearings, and a top priority of Secretary Sutter's and the governor. And I think we continue to believe that even especially in a post-COVID world, it will be important to think about how best to support and rebuild resiliency and capacity in these areas. As we'll talk a little bit about today, there have been a number of executive orders by the governor and Commissioner Burrell that have implemented changes in practice and policy that have been longtime priorities for the Health Policy Commission, specifically with regard to expansion of telehealth, expanded scope of practice, setting out-of-network benchmarks. And these are all temporary to the state of emergency, but we believe there could be a role for the Health Policy Commission to evaluate how the impact of these changes and to make recommendations about how they may be adapted to and sustained into the future. As Stuart mentioned, we have resources and data that allows us to understand health system structure and capacity that could be leveraged to inform future planning. And then finally, and we're going to talk a little bit more about this at our next committee meeting, using our ability to make innovative investments that, again, are targeted and thought about how we can best support communities that have been most impacted by COVID-19 pandemic. And make targeted investments upstream that will address social determinants of health, which we know will continue to be a top priority in the future. We'll talk a little bit more about that at the next meeting. But I'm going to pause there and just want to get any reactions or comments or further comments and reactions from commissioners on this slide and on this conversation. So I saw.
David, it's Marty. I would just ask that in your first bullet there on differential impacts that we add behavioral health providers, the amount of post-traumatic stress that's going to come out of this is going to be significant. We know from past mental health disaster work that it shows up 3-4 months after the disaster. And given the amount of loss, both death, illness, loss of jobs, loss of social interaction, I think it's something that we have to particularly pay attention to.
Yeah, absolutely agree. Thank you, Commissioner. I saw Commissioner Foley.
Yep, thank you, David. Nice to see all of you and the members of the commission. I just want to add my voice to what I think is a really great approach that we're taking here. I think the role of the HPC to do this work has always been critically important. I think even more so now to kind of take the lens and the view that you've outlined here. I think is really important. I support the direction as well as the comments from the commissioners. Clearly, the mental health and emotional support that healthcare workers in particular, but all of us in general are going to need is growing by the day. So I do think I support additional looks, reviews into that. I think one of the lenses that I'm looking at through this, and I think it plays out in some of the bullet points that are outlined here, is through the lens of disparity. Clearly there was disparity in the system in terms of providers and resources that they have, and did this exaggerate it or not? Particularly looking at some of the resources that David Arbach mentioned coming from the federal as well as the state government. Did that deal with any of the issues of spending during the pandemic? winners and losers. Unfortunately, they are. And I think that's really important, as well as some of the temporary changes and policies that we've supported. Who had access to that? Who didn't? How do we expand that? I think that goes to the targeted investment pieces. It seems like the research that you outlined will help support the innovative investments elements. But I just want to add, I think it's really important. I think looking through it through a disparity lens, we know that a lot of the community hospitals and safety net hospitals as well are also taking care of more COVID-19 patients than many of the other providers. I know Mass General has a lot, but there are many providers in the community that have an overwhelming amount of COVID-19 patients. As we know, communities of color in particular are being impacted more than others as it relates to this disease, both for their families and their communities, but healthcare workers live in those communities as well. So I just think looking at through that lens, and I think it seems throughout the bullets here, it's going to be really important for us. And I think the work that we're doing, again, is critically important. And I think the outline looks really good, so we can understand what impacts this has had on the delivery of healthcare and in the finances, as well as the opportunities to receive care, telehealth and others. And I don't know how it fits in here, David, then I'll stop, is long-term care. Clearly, nursing homes and home care is a huge part of our delivery system, and nursing homes in particular, as we all know, are 60% of all deaths are occurring in nursing homes. So the impact and how do we get at that, I think, is also a piece that we may want to figure out how to explore. I know it's a little bit outside of the outline here, but I think it's a critical part of reviewing what happened to our healthcare system during this crisis, what's currently happening, and what we need to do to ensure we're able to respond in the future.
Thank you, Commissioner Foley, and agree with your comments and would not suggest that this is the exhaustive list of all the different provider types and organizations that are being impacted at all. And I would just want to voice support for your comments. I think this commission has identified real challenges prior to COVID in disparities and inequities in consumer affordability for care. And access to primary care, access to behavioral health care. I think these challenges that we identified before will potentially only be greater in the future. And so how can we continue the work that we've done in the past through this new lens to be able to be a contributor to positive action at a Commonwealth basis? Commissioner Berwick, I saw that you had raised your hand. And then I'll turn to you, David.
Thank you, David. First of all, this is terrific, and it's going to be among the most important things the Commission ever undertakes, I think. I have a couple of quick comments, and then we'll presumably return to this in future meetings. Let me just endorse what Tim Foley just said about disparities, and particularly racial disparities. We are really seeing a dramatic difference in burden and outcomes for especially African American and Latino people in our state, as in all states. I don't think we should back away from that. It's a big deal, and I think we have a role to understand what's going on and what to mitigate in the future. It isn't just about COVID. Obviously, it's a long-standing problem in our Commonwealth. Second, I guess this is the next to the last bullet on your slide, but like the rest of the country, we got caught on our heels on this one. We were not prepared. And in order to become more prepared for future threats, there'll have to be investments by both public and private sector. And I think the Commission should spend some time understanding what preparedness really needs to look like, not just workforce overall, and implications for cost and investment in the Commonwealth. I think the tectonic changes in telehealth are going to be good for us all, and we really need to dig into that. I'm pleased to see it there. The last point I want to make, without hopefully being too dark, is we don't really know whether there will be an after COVID right now. There are some indications that we're going to see multiple waves for several years, and whether or not we get a vaccine is still up in the air. We do not know. There are no really effective antiviral agents yet. We could be stuck in this modality for far longer than we think, and hopefully not, but we need to keep that in mind as we plan ahead for the Commission's work.
Thank you, Commissioner. I'm going to turn over to Commissioner Cutler and then Commissioner Mastrogiovanni. But Commissioner Cutler.
Yeah, thanks. I actually just want to make a couple of comments. One is from the perspective of someone who studies the healthcare system and tries to think a little bit about how to forecast it. I think there's more uncertainty in forecasting it now than I've ever seen in about 30 years of doing this, between what's going to happen to the economy, to what's going to happen to the healthcare system, to what's going to happen to providers, to what's going to happen to patients and their willingness to seek out care. So I just think it's going to be incredibly important to be on top of it. One of the things that I wonder about is whether we can get more frequent refreshes of the APCD data, because I think that would really help us a lot to be able to monitor in closer to real time what's going on with COVID and medical care, and that might be our best way of doing so. We could also, if not that way, we could do surveys of physician practices, how many people are coming in, or how many of you furloughed, how many of you hired back, or so on. And that may be something that we or CHIA in particular would wish to do as well. But I think thinking about how we can get some of this data as it's going on will be important. And then finally, I also just think that some of the things we have called for over the years on which we haven't gotten as much traction as we would have otherwise liked are becoming really quite important. Like, for example, issues of telemedicine and of scope of practice restrictions on various medical care providers. All of them are sort of being waived in the short term, which is very good. And I think some of what we can do is we can be there to provide information. Has it gone like what we hoped it would? In which case that would continue to make the point that we have made, which is we think it would be beneficial to continue that. Or maybe it hasn't gone as well as we thought, and we should be open to hearing that too. So keeping track of some of these sorts of things will be very helpful for us as we report to the legislature and to the governor. And again, being able to do so in as near real time as we can will be important.
Great. Thank you, Commissioner Cutler. I'll just say one thing very quickly, which is that the Center for Health and CHIA has really been doing a great job of thinking about how to accelerate their data reporting cycles, both with the APCD and with hospital discharge data, which I think will be, this was work that was happening prior over the last 2 years. And we're well poised to be able to take advantage of some of that accelerated data reporting. Ron?
Thank you. By the way, great job with all the stats that David presented today. I don't want to take a lot of time. I just want to also endorse what Tim had said. And when we look at innovative investments, we really need to look at zip code, especially after seeing what's happened in places like my hometown of Chelsea. And we really need to focus on that.
Thank you. Any other final
Yeah.
thoughts or comments?
David, this is Stuart. These comments, this table here is probably the most important table we're going to discuss today. It really, in a snapshot, explains what is going to be our dominant discussion over the next several years. And I don't know how you allocate your resources, David, but I would hope that the commission staff would really increase the amount of effort in these areas. The comments made by my fellow commissioners, my own comments and yours, David, really reinforce that we are seeing a fundamental changes, a lot of which are positive with respect to the changing delivery system, particularly that bullet about evaluate the impact of temporary to whether they become permanent, but also the potential negative. If the end result of this is a further deterioration in our community hospitals and rural hospitals and a increased dominance of our academic medical centers, much as I have grown to love my academic medical centers, we do not want them to be the total delivery system in the new world. So this is an incredibly important area. And I look forward to the further discussion in June and ongoing to see how we can learn. And by the way, I would say one other thing. As David Cutler mentioned, I think we may want to do special surveys, but I think we ought to link them up with the national surveys that are being done by Commonwealth Foundation Fund and the Kaiser Family Fund and Millbank and so on, so that we sort of see what's best practices around the country as well as what we're doing here in the Commonwealth. So great job, David and David.
Great. Thank you, commissioners, for all of those comments and thoughts. And Stuart, as you mentioned, we knew this was an important topic to introduce today, and so wanted to be able to provide the time for this discussion, and do expect this will be a significant part of our discussion at future board meetings, and look forward to continuing to engage with all of you and with our colleagues across state government about how best to work together to help answer these questions. I know that we are already into the meeting time for the Care Delivery and Transformation Committee meeting. So for those of you who have logged in, hoping to hear part of that agenda, we're just running a little bit behind, but do think that we can make up some of our agenda here by moving through some of our next few items a little bit more quickly. Because every agenda item I do think is important and relevant to some of the topics, particularly on this slide. So in the interest of moving us forward, the next agenda item that we wanted to present, and David Auerbach is going to present on this, and I'm going to use my executive director prerogative to ask him to really hit the most important points so that we can move into the next committee's agenda. As was noted earlier, this is an area where the Baker-Polito administration did issue an executive order requiring insurers to cover all medically necessary ED and inpatient services, including professional services related to COVID-19, with no cost, for both in-network and out-of-network providers, with no cost sharing for the insured. And similar to some of the frameworks that this commission has recommended in the past in terms of a comprehensive solution to out-of-network billing challenges, it prohibits balance billing, and then also establishes basically a two-tier default payment rate for reasonable and fair reimbursement to those out-of-network providers. First, by saying if the provider is in network with that health insurer for any one of the products, they would be reimbursed at the in-network rate. And if the provider does not have any contract with that health insurer, that the default payment rate would be set at 135% of the Medicare rate. We have issued analyses before that looks at potential different benchmarks. There are different approaches that people have recommended with regard to solving out-of-network challenges and protecting patients from surprise bills. But this is related specifically to COVID-19 treatment in COVID-19 patients, but nonetheless provides a great opportunity for us to learn from this experience and to be able to apply those learnings to future policy discussions about how this protection might be extended to the entire population. In that vein, we have continued to work to try to understand the impact of out-of-network billing on Massachusetts patients. And so this analysis that we'll walk through for the next, I'd say, probably 5 minutes, David, is an update of analysis that we've really been tracking for many years on looking at claims data to be able to try to understand how often and to whom out-of-network billing scenarios are occurring in Massachusetts. And so this is in some cases updated data. It has new data up through 2017 and new health plans that really provided a more expanded view than some of our previous work on out-of-network billing. And I think the punchline here is in this gold box, which is to say, based on this updated analysis, we find that many indicators of out-of-network billing in Massachusetts have gotten worse over time. So David, understanding that I'm going to ask you to move quickly here, I'm going to turn this back over to you to just talk about this analysis. And I would note that this chart pack is available on our website today for the public and for stakeholders who are interested in diving deeper into these issues. But David, if you want to say a few words on this before we move on.
Great. Thank you, David. I'll be super brief. And again, there's a roughly 20 slide chart pack available on the website for all to see. And what we did in this case was update and expand upon an analysis we did about 3 years ago to again try to understand the extent of out-of-network billing in Massachusetts. And when we talk about this, we're really thinking about the set of out-of-network billing scenarios where the patient unknowingly did not have the ability to choose an in-network provider and still ended up being cared for by an out-of-network provider. We're not talking about somebody separately finding, let's say, a mental health therapist and paying knowingly their full rate in cash, something like that. But these 3 scenarios we have here are what we focus on in the analysis. Someone taken somewhere by an ambulance, an emergency scenario, someone receiving emergency care in an emergency department, and somebody receiving services from a radiologist, anesthesiologist, or pathologist. All scenarios where patients are doing the right thing, they're going to in-network hospitals, or they're just being cared for by someone that they did not have an ability to choose. They didn't know the price they were going to face beforehand, and yet they're still subject to a potential out-of-network bill and the charges by the providers in these cases. Okay. So very quickly, we looked at a subset of the claims in our all-payer claims database where the insurers had filled out data allowing us to identify this is an out-of-network scenario. And that covered about 650,000 patients. And of those, we found 68,000 out-of-network claims for over 30,000 patients who faced out-of-network billing and about 45,000 encounters. So some patients had more than one out-of-network billing encounter. And these divided up across those 3 scenarios I just showed. About a quarter were somebody in an ambulance, and the rest were professional services. About 10,000 of these encounters were in an emergency department, and about 24,000 were services provided by one of these radiology, anesthesiology, and pathology providers in settings outside of the ED. Okay, and the next couple of slides break those down further to identify which types of physicians or providers are involved. Here, about half of those in the ED were not surprisingly ED physicians, and a significant number of radiologists also. Okay. And of those claims from the so-called RAP providers, most of those occurred in outpatient settings, such as outpatient surgery, where a film was read by a radiologist or analysis by a pathologist or anesthesiologist. Some of the anesthesiology claims were in an ambulatory surgery center as well. Okay. And the main implication that I'll spend 30 seconds on or so is financial. The main problem is, again, these patients are seen by a provider unknowing to them for whom there was no contracted rate. The insurer did not have a contracted rate with that provider. And so what they are facing is the provider's charges. And what happens when a patient is seen by an out-of-network provider? Several scenarios that we are able to observe and we break down in the table below. In about 7% of these cases, the insurer just paid the provider's charge, whatever it was. In a very small number of cases, the patient paid the full charge. And again, the main problem is these charges are very high, often several times higher than those in-network agreed upon rates when there is a contract. And in 90% of the cases, what the patient paid and what the insurer paid was not as high as what that provider charged. Those are the cases we're especially worried about, because then the provider might issue a separate bill on the side to that patient saying, hey, you owe me the rest of this charge. And we as the HPC would not see that transaction. So we don't know how often that happens. But those balance bills, so-called surprise bills, can be very high. In the next slide or two, we note how high those charges could be, often in the hundreds and thousands of dollars. And here we're just showing on average, more than $100 and several $100s, and it varies by specialty. For anesthesiology, the median charge was $500 or higher. Okay, and so the implications of those high charges are that not only can a patient be facing a very high bill that they often have no ability to pay, but the insurers are typically picking up a large amount of that charge. And those costs get passed around in terms of higher premiums across all members and all residents of the Commonwealth. One recent estimate by Zach Cooper was that just out-of-network charges and bills by those providers we identified raise overall premiums by about 3.5% versus if they were not able to bill out-of-network. So these are the main implications that we are making recommendations about in the Chartpack, mainly to follow something along the line of the temporary order where we have some limit to how high those charges can be in out-of-network scenarios where patients had no ability to understand the price they were going to be faced for this care. So I'll turn it back over to you, David.
Great job, David, moving through that relatively quickly. And again, the Chartpack is available on our website, but just want to pause to see if there are any comments or questions from commissioners on the out-of-network piece. Okay, great. Seeing none, I think we are able to adjourn the Market Oversight and Transparency Committee and move to our next meeting of the Care Delivery Transformation Committee. So I'm going to turn it over to the chair of this committee, Commissioner Blakeney, to just introduce the topic really quickly and lead us through, again, our approval of the minutes. So I'll turn it over to you.
Thank you and good morning, everybody. I think we all agree that the content of the MOAT meeting is critical work, and I'm glad we had the opportunity to review it to the extent that we were able. So let's move quickly through our agenda here. We have minutes to approve. We have Commissioner Cohen and Undersecretary Peters, as well as myself, were participants in that meeting. So I'm not sure if Commissioner Peters is on at this point. Then Commissioner Cohen and I guess it falls to us. Are there any corrections?
Commissioner Berwick is also a member of the committee and can vote on the minutes.
Oh, okay, because I don't know if Commissioner Berwick was at that meeting. Don, do you recall your?
I believe I was, Barbara, but maybe.
Okay, I'm sorry.
Don't
Okay,
trust my memory.
Okay, I'm working off of a cheat sheet here. So may I have a motion to approve the minutes, and then we'll make corrections?
So moved.
And seconded. Are there any corrections to the minutes? Hearing none, then I vote in favor. Commissioner Cohen?
Aye.
Commissioner Berwick?
Aye.
Okay, and is Commissioner Peters with us yet? Okay, then I believe the minutes have been approved. David, let me turn it back to you and to Kelly. And hopefully we can get through as much of this agenda as it's possible in the remaining time. So back to you, David.
Great. Thank you, Commissioner. I do want to recognize that Commissioner Kreider just joined us. Thank you, Commissioner, for participating today. We are just beginning the care delivery transformation portion of today's agenda. The next agenda item is really an update on a program that we've been working on with our sister agencies for over a year in developing this really new innovative program. And so I want to give an update on this program as well as next steps, and just want to highlight that I think the importance and relevance of this program is only heightened by the current situation in the healthcare system. And so I think this innovative investment, as we kind of talked about at the last board meeting, provides an incredible opportunity for us to make proactive investments that will have tremendous long-term benefits. And so with that, Kelly, I will turn it over to you, our Senior Director for Policy for Healthcare Innovation and Transformation.
Unmute. Good morning, commissioners, and thank you so much, David, for giving me the opportunity to provide an update on a program we are really enthusiastic about called Moving Massachusetts Upstream, or MassUP. As we've discussed at several previous meetings, I think it's safe to say, even based on the comments from earlier today, that there is a growing consensus that addressing the social determinants of health is critical to any effort to improve outcomes, lower cost, and address health disparities in the Commonwealth. Next slide. And I would say, I think we missed a slide. Did we? Okay. In any case, I think one of the things that is certainly important here is that, as many people have pointed out already, that the experience with COVID-19 has made that point even more starkly, as we recognize that poorer communities and communities of color are seeing disproportionately more cases of the virus and more deaths, and are certainly likely to feel the economic effects of the pandemic in the form of deeper social and health inequities. And so it is with this backdrop that we see MassUP, whose vision is better health, lower cost, and reduce health inequities across communities and populations in Massachusetts through partnerships between government, healthcare systems, and communities. This is, it's important to point out, a partnership across state agencies. We are working closely with the DPH, with Mass Health, with our colleagues at the Attorney General's Office and the Executive Office of Elder Affairs, with the goal of engaging in policy alignment activities and investments to support the healthcare system and community collaborations. And so for our purposes today, I'm going to limit my comments to the investment program. Next slide. So I think I show this slide all the time, and I'm going to keep showing it because I think it's an important one just to distinguish what is unique about MassUP as opposed to other work that we support and in some cases fund. Many health systems and community-based service organizations are doing incredible work in what we think of as the downstream space. And when I talk about downstream work, I mean doing things like providing short-term housing solutions, providing transportation for patients to medical office visits, potentially food vouchers or food prescriptions. That is all incredibly important work and that we would absolutely support. That is not MassUP. The specific goal of MassUP is to build or expand on those types of efforts to implement programs that move farther upstream in addressing the social determinants of health and the root causes of poor outcomes and health inequities. So while a downstream effort, for example, might focus on providing a food voucher to a patient, an upstream effort would work to address broken food systems that affect the health and well-being for an entire community. Next slide, please. So with that in mind, we structured MassUP to encourage partnerships between healthcare delivery organizations and at least one community-based organization to address a significant social determinant of health in the communities that they together serve. Underlying those partnerships are deep engagement with community members in shaping and executing the programs, and equitable governance structures to ensure that engagement continues throughout the life of the project. To support these partnerships, we, in partnership with the Department of Public Health, are offering $2 million in total funding for 3 to 4 awards of up to $650,000 each, for a 3-year award period that includes up to 6 months for planning and then roughly a 30-month implementation period. Next slide, please. Period. So requests for proposal were made public in mid-December 2019, with responses due on February 26th. The HPC received 22 proposals from a range of applicants, including hospitals, ACOs, and community health centers. Many of these organizations were alumni of previous HPC investment programs. And in total, the applications requested about $14 million against our $2 million budget. So I can say we were enthusiastic with the response, about the response. Next slide, please. So the areas of focus represented in those proposals covered a diverse mix of focus areas, everything from transportation to housing, broad issues of social inequity and economic stability, immigration status and the downstream impacts from that, food security, and early childhood needs were all represented in these applications. Next slide, please. So as part of our procurement process, we convened a review and selection committee and assembled a bench of subject matter experts who could assist the review and selection committee in evaluating the applicant's proposals. In making and undertaking those reviews, we considered 5 key domains. First, the strength of the applicants and their partners. And when I talk about the strength of the partnerships, we really did look for histories of prior working relationships. One of the decisions we made fairly early in the design of this program is that we thought we would be most effective and have the greatest impact if we functioned as an accelerator rather than an incubator. So we're looking for situations where there had been some sort of nascent work, or maybe work that had gone as far as it could, that could be expanded or built upon with our investment. We also looked at whether or not these providers were mass health providers, whether they were certified ACOs, and if, as I mentioned, we had several alumni, so we also took into account our experience in prior awards. The second thing we really considered was the proposed program. And first and foremost, we considered the alignment of the program with the MassUP opportunity. So again, we were really looking for proposals that didn't just try to solve an immediate term need for a patient population, but really look upstream to try to understand the underlying systems that were leading to disparities in poor health. As we reviewed the proposed programs, we also looked a lot at how well they demonstrated the understanding of social determinants of health in their community. And I will say, just as a personal note, I mean, in some of the proposals, they were fascinating. They were interesting. They were very, very thoughtful, and really provided, I think, a level of insight that was truly impressive. We also took a long look at the feasibility of the programs they were proposing to address the social determinant that they cited, and the extent to which the applicants incorporated racial equity principles into their approach to the work. As we looked at a third key feature, I should say, is partnership governance and oversight. One of the things that we understood going into this program is that there wasn't necessarily an assumption that all players would traditionally come to the table as equals. You can imagine large health systems sitting across the table from small, really effective, but not particularly resourced community organizations, or actually members of the community themselves. So we really wanted to make sure that the partnership governance and oversight approach really fostered equity and enabled accountability. Another key feature was the extent to which the governance and oversight models really seriously incorporated the community in decision making, and through all, not just in the design of the programs, but through all aspects of the management. Finally, obviously, partnership budget and operations were a key feature. I will note that we looked carefully to ensure that there was at least one full-time employee who was exclusively dedicated to the work of the partnership. That didn't mean that there couldn't be more, but one of the things in the stakeholder engagement we did prior to launching the program was do a lot of national research about who had done similar programs. And one of the things we heard pretty consistently is that to make these programs successful, somebody needs to get up every day thinking about them, not doing it on the fringes of their day jobs. And finally, we considered sustainability. Obviously, we cannot fund these programs forever, so we really want to make sure that we are setting them up to take the work over. And in doing so, we looked specifically at the potential for alignment of funding streams and alignment of strategies, so that this, I think we hoped would feel less like a side project and more like an integral part of their day-to-day business. So we had this beautiful process. It was running beautifully. Everything was on schedule. And we had a global pandemic drop into the middle. So we did a little bit of adjustment on the fly. And as I said, we continued through our review and selection process. But I think, as we've discussed in so many other ways, it would be naive to pretend that the world wasn't changing around us. So in addition to our normal process of reviewing applications, we also recognized that when we issued our RFP in December and the applicants submitted their proposals in February, we weren't imagining the situation we're in today. So with that in mind, we took an additional step of reaching out to some of the applicants simply to get a sense of whether the program still made sense in light of COVID, whether the kinds of programs they were proposing, felt relevant, and whether the timetable we imagined was feasible in light of the other things that were consuming their attention. So what we heard was not only that MassUP was still relevant for all the reasons I think that commissioners cited in some of the early conversation, but that the pandemic created a heightened need and ironically, a unique opportunity to address upstream issues. I think one of the things we heard was that because of COVID and because of the terrible disparities in outcomes and impact, people are paying attention to upstream issues in ways they maybe haven't in the past. And this was an opportunity to capitalize on that. So while we anticipate that if selected, some applicants may need to make some tactical changes to their proposed programs. For example, if you imagine programs that prioritize community engagement, it's going to be hard to do that in face-to-face meetings. So I think we can expect that we'll see some transition to use of technologies and things like that. What we did not hear was that the proposals that we reviewed would require significant modification as a result of COVID, or that the implementation timelines proposed would be seriously affected, which brings us to where we are today. So our hope and expectation is that we will present recommended awardees to the board for review and approval at the June meeting. And if that goes as planned, our hope is that we can kick off the contracting process in the summer. And because we've had a little bit of extra time, the MassUP team has been trying to get all their ducks in a row for that process so that we can move expeditiously when it's appropriate, and then launch the program September 1st or earlier based on the desires and abilities of the awardees. So, I think September 1 is probably right. We'll see. If that happens, then the implementation period would effectively be March 1st, 2021. So that is where we are, and I'm happy to answer any questions.
Yeah, Kelly, I'll just say fantastic work. This is so methodical and thorough. I'm really impressed. Thank you for all your help. Can you explain the interval between September and March? Why does it take that long to start implementation?
Yeah, it's an excellent question. I think one of the things that we recognized in designing the program was that in some cases, we were asking people to do new things, even though they had prior working experience. We were asking them potentially to work together in new and different ways. So we wanted to offer the opportunity to spend some time doing a little more planning together before they launched. Another thing we recognized was that for some, doing real authentic community engagement would take some time, and in order to sort of influence the design of their program, so we wanted to allow time for that. It is not required that they take the full 6 months. I would say by and large, the applications that we reviewed, most organizations did.
Thank you.
You're welcome.
Kelly, there's, given that you had 22 applicants and they represent different institutions, there's almost an opportunity for a little natural experiment here by picking different kinds of organizations as grantees. Are you giving some thought to that?
You know, I think we're very open-minded, obviously. I think interestingly, there are a lot of natural experiments that could come out of this. I think certainly one is different types of provider CBO partnerships. I think another thing is natural experiments potentially around focus areas. So all of that is kind of part of the gestalt of coming to the final recommendations. But it's a good point. Other questions? All right.
Hearing none, I think we're ready to move on. Thank you, Kelly. That's great work. And I think we're all anxious and excited to see how this whole program plays out. It's somewhat of a new activity for us, and I think it's exciting. So well done.
Thank you.
So great. So moving on to our next agenda item, this is a slightly shorter one, but did want to touch base quickly on telehealth, an issue that we have talked about many times already this morning. Wanted to highlight that this was an area where the administration, the Baker-Polito administration, took swift action through an executive order to ensure that members and residents of Massachusetts had access to telehealth services in the same manner that they would be able to access in-person services. MassHealth, our MassHealth program, had already led the state in allowing for some telehealth, and that was expanded as well. And I would note that the order requires that the payment for these services be no less than the rates paid for in-person services. So again, I think this really provides, as we've talked about many times, a natural experiment to try to understand how has this executive order expanded access to telehealth? How have members been able to access these services? How have different populations perhaps faced challenges in accessing these services? And particularly also what clinical services are most appropriate for this type of modality of communication and healthcare delivery. And so I think all of this will be a great area of interest for many across the country, but certainly here in Massachusetts as well. And this has been a top policy priority for the Health Policy Commission for many years. I would note this is the experience of one of our major commercial health plans, and showing a dramatic increase in the number of telephone and virtual visits from a 2019 monthly average to March 2020, a very significant increase. I would note this is just one health plan's experience, and different health plans had already some telehealth services available and were well poised to be able to scale that up. And so we may see differential impacts depending on the health plan. But I think we really want to be able to understand where this new utilization has occurred and what the impact of that has been, and would note and highlight that the work of the Division of Insurance, our DOI colleagues, are collecting information from all of the commercial health plans in Massachusetts, specifically on telehealth utilization during this time, which will be a great data source for many state agencies to be able to tap into to understand what's happened in this natural experiment. Related to telehealth, though, we did want to just take a few moments to share some findings from our own work in telehealth. We Also, the Health Policy Commission administered a telehealth pilot program a few years ago at 4 sites across the Commonwealth, specifically focused on using telehealth to increase access for behavioral healthcare services for a range of very specific populations. And given the collective interest in telehealth at this moment, just wanted to have a very few number of slides here to share some top line results from that investment program that the HPC administered. So Kelly, back to you for some highlights from our evaluation results.
All right, thanks so much, David. So as David mentioned, this investment program was launched in summer 2017 as part of the Healthcare Innovation Investment Program portfolio. And it was broadly intended to further the development and utilization of telemedicine in the Commonwealth. So the HPC provided a total of $1.7 million to support 1-year regional pilot programs, specifically, as David mentioned, to increase access to behavioral health care using telemedicine for some very specific populations: children and adolescents, older adults aging in place, and individuals with substance use disorder residing in the Commonwealth. So through a competitive process, 4 awards were made to 4 quite different types of programs. Haywood Hospital partnered with 2 schools to offer telebehavioral health sessions during the school day for middle and high school students. The Pediatric Physician Organization of Children's Hospital Boston worked to offer telepsychiatry consults in pediatric primary care offices. The Riverside Community Care partnered with 3 local aging service access points to offer telebehavioral health counseling sessions in the home, specifically for homebound elders. And UMass Memorial Medical Center offered telepsychiatry consults and a suite of substance use disorder services for patients in the inpatient setting with substance use disorder. Next slide. So we're still in the process of completing our formal evaluation of the telemedicine investment program, but we're able to provide some interesting, I would say, implementation insights at a high level. And as I think part of the discussion earlier today was, it is so important as these programs roll out to learn both what works and what doesn't. And we've learned quite a bit from these particular examples. So first and foremost, I think what we learned was that telemedicine programs have proven to be quite flexible and have broad applicability. All 4 programs successfully engaged patients in tele-BH care across a variety of settings and patient populations, and really succeeded in expanding access to behavioral health services for populations that just weren't able to get this care. The second was that telemedicine was generally welcomed by patients and actually offered some unanticipated benefits. Patients generally express very high satisfaction and comfort with the telemedicine platform. I think one of the surprises as we've looked at the data from the evaluation, and I suspect this was a bit of a surprise for some of the awardees as well, is that some of the initial concerns they had that patients just wouldn't get the technology didn't really materialize. And in some cases, the telemedicine platform allowed clinicians to connect with patients in new and arguably better ways. So a specific example of that is in the Haywood pilot, which was with the schools. The clinicians used telemedicine to actually play games and electronically chat with students who actually weren't comfortable in sort of a more traditional, conversational therapeutic interaction, and they felt that they were able to make more progress with telemedicine. I think the other important thing that we've learned from these pilots is that telemedicine isn't really, for want of a better term, an island within healthcare processes and workflows. The implementation process generated a lot of lessons about how to establish a program. In addition to just figuring out the technology, also thinking about having to develop appropriate staffing models, workflow adaptations, and necessary wraparound services to support patients before, during, and after their tele-BH sessions. And I think it's these kinds of insights that are going to be really invaluable as we start thinking about, if the growth of telemedicine and how to actually make it a really long-term effective solution as opposed to, sort of a stopgap measure. Finally, I would say overall, provider reactions were very, very positive, but there were still some workforce issues. In general, participating BH clinicians felt comfortable providing their service via telemedicine and felt that they were able to provide a similar standard of care to what they would do in a traditional office visit. And referring providers were extremely happy that they could offer behavioral health services to patients that they hadn't been able to serve in the past because of access challenges. One of the things that we did recognize, though, is that some paid programs still identified a shortage of behavioral health providers who are comfortable providing care through this modality. And sometimes that created challenges with access even within the BH framework. So I think that's something that we'll want to keep our eye on the future in terms of how do we enable BH providers and other kinds of providers to feel more comfortable with this platform. So some sneak preview of the data highlights. We're still looking at our numbers, and we're still looking at our qualitative findings. But overall, I think we can say about 780 patients were served across the four target populations, excuse me. And these 780 patients represented more than 1,600 telemedicine sessions. And it's not worth getting into in detail now, but I think, how you actually parse that out is a fairly nuanced thing that we'll address in the evaluation. Of those participants surveyed, over 85% of patients and families expressed satisfaction with the care they received through the programs. Also, each one of the programs was able to demonstrate some notable success either in expanding access and or in improving their targeted outcomes. So with the pediatric physician practice at Children's Hospital, they were able to decrease wait times for a psychiatric consult by 37%. At Haywood, their approach to offering behavioral health sessions in the school during the school day avoided an estimated 6.3 lost school days. And that's really because without the services being provided on site, kids would have to go off somewhere else, would have to leave, parents would have to leave work. So it was a really significant finding. UMass Memorial was able to initiate or maintain medically assisted treatment for a number of their patients during 188 hospitalizations. So to be clear, what UMass was doing was actually doing teleconsultation with psychiatry while patients were in inpatient beds. So in the past, they hadn't been able to offer that, they could through the service. And finally, 89% of patients with depression served by the Riverside program saw a decrease in their symptoms as measured by the PHQ-9. So as I said, this is a sneak preview, so hopefully there will be more interesting things we can share. We're in the process of drafting the full evaluation report and developing an impact brief on the program that are slated for release this summer, and we look forward to sharing more findings then. I'm happy to answer questions now if you have them.
Thank you, Kelly. Are there questions for Kelly? Hearing none, then Kelly, thank you. It's having been the recipient for the first time of a telemedicine visit. I can tell you it's a different experience, but I was grateful for not having to go out and get in the scrum, as it were. So thank you very much for that. Our next agenda item is the nurse practitioner workforce. And so David, I'm going to bring it back to you.
Great. Thank you, Commissioner. And just to put a button on the previous conversation, I think it's important with telehealth to think about both the coverage and payment pieces, but also the actual implementation realities on the provider side. And I think that's a place where we'll be able to really provide some insights about how the providers and their partners were able to make this work really well for patients and families. So I think both things go really importantly together. Our final agenda item today is on the nurse practitioner workforce. And again, want to highlight swift action by the Baker-Polito administration in issuing an order allowing for advanced practice nurses with 2 years of supervised practice or equivalent practice to prescribe without supervision during the COVID-19 state of emergency. This has been, again, a policy priority area for the Health Policy Commission for many years. And provides, again, another natural experiment to evaluate and to think about how we might be able to support the permanent relaxation or permanent removal of these outdated scope of practice restrictions on advanced practice nurses. Recognizing the time, David Auerbach, I'm going to just try to quickly walk through this myself. May call on you for some additional commentary. This is a policy brief that we have now written up and is available on our website. So much like the out-of-network chart pack, this is a fully written policy brief. Encourage you to, everyone on this live web stream, to check that out and to share it with your communities. But David Auerbach, I don't know if you want to just try to hit the most important points from these slides in our final 5 minutes here.
Yeah, yeah, I'll do that quickly, and thank you. We have been talking about and making recommendations around this issue for a while now, and what's exciting right now is that this is the first time we actually have some data from our APCD that we can bring to bear to understand the involvement of nurse practitioners in care in Massachusetts. And this slide highlights again the main policy issue that a dropping number of states, it's now only 22, continue to maintain these restrictive scope of practice laws. We're the only state in New England that does. And as you saw, the Baker-Polito administration has lifted these temporarily, acknowledging that all the evidence finds that these restrictions do not improve quality of care. And in fact, quite the opposite. They reduce access to care and reduce quality of care in a number of areas. And so we continue to recommend that these laws should be removed. In Massachusetts specifically, they require all nurse practitioners to have an agreement, a collaborating agreement with a physician, and physicians oversee the prescriptions that they write periodically. Okay, so just some background again on NPs. About half work in primary care. There is on the order of 6,000 working in Massachusetts right now. The supply is growing over time quite a bit. And I've already summarized the research to some extent, but removing these restrictions have been found to increase primary care access and decrease ED use. On the next slide, we show just a little bit about NP's involvement in care in Massachusetts. You'll note on the left that very few are actually formally assigned as their patient's primary care provider by their insurer, but more of them are actually the primary deliverer of care for patients, growing to 6%. And when you actually count how many primary care E&M visits, NPs are providing up to 14% of those in 2017, and that's certainly growing. It's even more today. Next slide just shows some characteristics of how do patients who have an NP as their primary provider differ from patients who have a physician, and a couple of notable things here where they're more likely to be female, more likely to be younger, and have lower total spending. On the right, even when we adjust for characteristics of those patients, spending still is lower, which is an important finding. The next slide just notes that when we look at what kinds of patients have NPs as their primary care provider, they're more likely to live in low income areas of the state. And you can see that very clear trend that NPs are more involved in care for low income underserved areas in the state. And not only does that hold by income, but on the next slide, you can see that NPs are more involved in care of rural residents in the state. So again, supports the findings that access would be improved if NPs were more were released from some of these scope of practice restrictions. They are also more involved in care for MassUP patients than for commercial patients. Okay, and finally, the last issue I just want to note is that there's a billing issue that we also recommend be removed or be changed, where for the most part in those yellow bars, those are cases where the NP provides the visit and they bill directly to the insurer and the insurer pays for the visit. In those cases, NPs are generally reimbursed less than physicians, and that's how the Medicare program works, and that's how most private insurers work, usually at about 85%. In those minority of cases in the blue, and it's probably more than that, there's sort of an interesting rule where NP is allowed to bill as if they were the physician at the full physician rate. And this occurs sometimes, but it's hard to know exactly how often it occurs because in the claims record, it looks just like the physician provided that visit where they did not. But we have a special modifier on our claims data and the private insurers submit, which allows us kind of uniquely to be able to see how often this is happening. This practice raises costs, it does not increase quality, and it also makes it confusing to assign accountability for that visit when you don't actually know who provided the visit. So MedPAC has recommended that Medicare end this practice. We also recommend that private insurers do not continue to use this practice. So that leads us to the final slide where we make the recommendations in the full policy brief that you can see, where we recommend eliminating the scope of practice restrictions, eliminating this, it's called incident 2 billing practice, and that NPs be allowed to provide care at the top of their license and increase access to care across the state, even beyond this temporary period, which we will certainly, as David said, study and try to learn from what's happening in this so-called natural experiment.
Thank you, David. That was extremely efficient. And thank you, Commissioner Blakeney, for leading us through that agenda item.
David, just before we leave that, I'd like to just make a couple of comments on this. Number one, nurse practitioners and advanced practice nurses as a category of practice have probably been the most studied role in all of healthcare. There are thousands and thousands of studies demonstrating what David Auerbach just spoke to, which is quality of care is superb and frequently, especially in certain settings, meets and often exceeds physician care in the same categories. So it's way past time for us to be able to move this discipline to its full provider possibilities. And so I as a retired nurse practitioner, appreciate especially the work of the commission on this topic. And I look forward to us being able to continue to advance this concept beyond the COVID-19 situation. And especially, I think it's very appropriate. Today happens to be National Nurses Day. And so it's timely because of that alone. So thank you for the work that we're doing here. I think it enhances practice across the board. And I look forward to being able to claim this as a permanent outcome of the work that we're doing. So thank you. Thank you, David.
Thank you, Commissioner. And I do want to offer an opportunity for other commissioners to weigh in on this particular topic or any of the topics from the Care Delivery Committee. I know that many of you have had an interest in nurse practitioners and the workforce issues in particular as well.
Yeah, David, I'd like to reinforce what Barbara and David Auerbach said. This is a very important study, and it's a very important issue. One of the areas that I would like to see us do more work on is it's clear that it's been adopted more quickly in lower economic areas. On the other hand, I would not rule that the higher income areas are reacting negatively. They're just not seeing it because you have more physicians per capita in those areas. And I think faced with the reality, but on the other hand, they're probably not getting as timely results. So I think I want to reinforce Barbara's comments that, when even high income areas are faced with these kinds of choices, they were willing to accept the advanced nurse practitioners as well. So good job. Thank you.
David, this is Don. Two quick comments on telemedicine. I think that I'm really glad about both of these, actually, telemedicine and nurse practitioner expansion. We need to keep our eye on quality of care and safety issues of telemedicine. I think they're going to be fine, but that needs further analysis over time. Second, the short-term decision to reimburse telemedicine at the same rate as equivalent visits, totally understandable and pragmatic. But I think we should dig deeper into what pricing in telemedicine might look like in the future and what it should look like, just for a placeholder there. Thanks.
Just a couple of comments. First, I started working with nurse practitioners 35 years ago. So I am a fan. I wondered from a data collection standpoint, will we have the ability to look at prescription drugs that were prescribed? So is that in our purview as we move forward?
David, do you want to answer that?
Yes, we do, and we have done some of that. Do you mean specifically comparing prescriptions by NPs versus physicians, or just more broadly?
No, comparing. Yeah, I think it'd be really useful to know what fraction are antibiotics, which fraction are scheduled drugs, and so on.
Mm-hmm. Yes, I think we've done some of that, which I could share with you afterwards.
Yeah, it's a great point, Commissioner, and we can observe that in the claims data, and so can follow up on that analysis.
And the last thought is on telemedicine. I believe it is absolutely here to stay. I think we'll see enormous ramifications. And I think a lot of it's going to become consumer driven because it is so much easier. And you know, the old guild business model of get in the car, you know, or get on public transportation after making an appointment, that took time. Driving in and then sharing space with sick people and then waiting, and that, I mean, it's just a remnant of a business model that is changing in front of our eyes, and it makes physicians more efficient in providing care, which a lot less overhead. So it's a really wonderful silver lining that comes from the COVID virus. I'd never go back.
Thank you, Commissioner. So with that, I just want to, we can adjourn today's meeting. I just want to thank the board members for all of your participation today, and for all of you who stuck it out through both meetings and a little bit after. Really appreciate the dialogue and conversation today. I think we at the staff level have a tremendous amount of work to do, and excited to be able to execute and move that forward. Our next regularly scheduled board meeting is not that far away, June 10th. So we will be back in contact with you very shortly to be able to prepare for that significant board meeting and some important follow-on conversations from today's committee meetings. So with that, Stuart, I don't know if you want to say any final words, and then we can sign off.
I want to, what Chris just said, we may want to take it even to ourselves. Much as I just want to commend you, David, for taking us through this stuff and some complicated stuff. It really went well. And, you know, not that I really look forward to seeing all of you, but this was done well. And we may even want to think about expanding this in some other areas, not for ourselves. It was a very efficient way of putting a lot of material together. So much as I look forward to seeing everybody, I think we should take it upon ourselves to learn lessons that Chris just pointed out. But great job. Thanks a lot.
All right. Thank you, Stuart, and happy National Nurses Day. And with that, I think we will close today's meetings. Thank you very much.